Welcome to Pathology Central Key Concepts. The topic of this video is pathophysiology of fatty liver disease. In this video, I will compare and contrast the pathophysiology, clinical features, and morphologic findings seen in the two types of fatty liver disease, alcohol-related and non-alcoholic fatty liver disease. Let's begin first with a quick review of liver anatomy. This is an image from Robbins and Kumar Basic Pathology showing here a hepatic lobule. The central vein is at the midpoint, and here at the apices we have our portal triads that consist of the portal vein, hepatic artery, and bile duct. Another way of thinking about the anatomy of the liver is in an acinar architecture, which we can see here. This refers here these zones to the zones of perfusion as oxygen is removed from blood from the hepatic artery as it traverses the liver towards the central vein. Now, what this brings together is that something very interesting is happening here in this area. This is referred to as the central lobular zone. One issue that's important here is that the enzymes that metabolize alcohol, such as alcohol dehydrogenase and cytochrome P450, are very active in this zone, which means that if we have the buildup of toxic metabolites, such as acetaldehyde, or the generation of reactive oxygen species, we can get injury in this area. Also, we have decreased oxygen tension since it is furthest away from that portal triad, and this can become a factor when we have injured cells. Now this takes you back to the Chapter 7 of Robbins and Kumar Basic Pathology, Environmental Pathology, in which we discuss the metabolism of alcohol. There is a video on this on Pathology Central as well. I just wanted to show you this to remind you of a couple of features. One is that we have multiple pathways for alcohol metabolism. So we can have metabolism here in the endoplasmic reticulum through the cytochrome P450 system. We can have it in the cytosol with alcohol dehydrogenase, and we can also get it here in the peroxisome using catalase. But all three pathways are going to lead to the generation of acetaldehyde, which is a toxic metabolite. Another factor that I want to point out is that these various processes are going to result in the generation of a fair amount of NADH, which is reduced nicotinamide adenine dinucleotide. This is going to become a factor when we look at the pathogenesis of alcohol-related injury. So when we talk about fatty liver disease, we've long known that there's an association with alcohol consumption. More recently, we have learned about an association with insulin resistance and metabolic syndrome. This is referred to as non-alcoholic fatty liver disease, or NAFLD. Some gastroenterologists and pathologists, as well as patient groups, have found this term to be somewhat uncomfortable because of the link to alcohol here. And there's been some suggestion of moving this term to metabolic-associated fatty liver disease, or MAFLD. Both alcohol-related fatty liver disease as well as non-alcoholic fatty liver disease are characterized by three features: steatosis, steatohepatitis, and fibrosis. And we're going to go through each of these in turn. Let's begin by looking at these in the framework of alcohol-related fatty liver disease. So alcohol-related fatty liver disease accounts for about 60% of chronic liver disease in Western countries, and about 40 to 50% of deaths due to cirrhosis. Now, in order to understand the natural history of alcohol-related liver disease, let's look at the progression. So if you look at all of the patients who chronically consume excess alcohol, 90 to 100% of them will have steatosis. Of this group with steatosis, 10 to 35% will develop a worsening image, which is called steatohepatitis. Of the individuals with steatohepatitis, 8 to 20% of these patients will develop cirrhosis. And of these individuals with cirrhosis, about 10% will develop hepatocellular carcinoma. Now, one thing I'd like to highlight is that with abstinence from alcohol, we can get regression of some of these changes. So steatosis and steatohepatitis are readily returned back to normal with abstinence. With cirrhosis, we don't return back to baseline, but we can get marked improvement of liver function with abstinence. So this is just a beautiful figure from Robbins and Kumar Basic Pathology that I think puts this all together. So let's begin here first with our healthy liver. In this circular image here, we see our portal triad, we have our central vein, and we have the plates of hepatocytes leading towards them. Now, if an individual consumes a certain amount of alcohol, this can lead to steatosis, which is going to be the deposition of small and large droplets of lipid within the hepatocytes. This is referred to as micro and macrovesicular steatosis. We can also see a little bit of perivenular fibrosis. Remember, this is our central lobular region. This is the area where most alcohol is being metabolized, where we're getting the generation of acetaldehyde and reactive oxygen species. Now, if this patient then abstains from alcohol, we can get a return to the normal liver. If the patient, however, continues to consume alcohol, we can get progression to cirrhosis. But let's leave that for a moment and return back to our healthy liver. So we can develop steatosis through moderate alcohol intake. If we have severe exposure, we may transition directly from the healthy liver to steatohepatitis. And what we will see here is necrosis of individual hepatocytes, steatosis, as well as some inflammation, primarily neutrophils. We can get this pericellular fibrosis, which is extending from our central lobular area. This is referred to looking like a chicken wire fence, and I'll show you a histologic image in a bit. We can also see ballooning of hepatocytes where they become quite enlarged and where the intermediate filaments collapse within. This is referred to as Mallory-Hyalin. Now again, even with the severe exposure, with abstinence, we can return back to our healthy liver. But now let's look at our end-stage liver disease here and how we get there. So we may go from our healthy liver to steatosis, continued exposure taking us to steatohepatitis, again, some more exposure leading us to cirrhosis. And what we see in cirrhosis is this very nodular liver. It is composed of these hyperplastic nodules of regenerating hepatocytes that are going to be separated by these dense collagen bands. So with that background in mind, let's begin by talking about steatosis, what causes it, and what it looks like. So how does alcohol consumption lead to steatosis? Ethanol metabolism, as I mentioned, is going to generate large amounts of NADH. When we have large amounts of NADH, it's going to shunt our fatty precursors from catabolism to lipid biosynthesis, which can then accumulate in the hepatocytes. Furthermore, alcohol itself impairs the assembly and secretion of lipoproteins, thereby again retaining fat within the hepatocyte. Now, grossly, the liver is going to be markedly enlarged and heavy. It will be soft and yellow, as well as greasy due to the large amount of lipid. Microscopically, in early insults, we will first see our steatosis around the central lobular hepatocytes. With continued exposure to alcohol, this can spread throughout the liver. And what we will see again will be these micro and macrovesicular droplets. Here's just a single image showing you steatosis of the liver. And to be honest, when you look at this, it's not immediately apparent that this is liver. These actually look just like adipocytes because the hepatocyte has been completely filled with this large lipid droplet which pushes the nucleus to the side. Here we can see some of this microvesicular steatosis with these tiny droplets in these hepatocytes. Now, with progression, we can move on to steatohepatitis. Now, the mechanism is not exactly clear. It's thought this may be due to the production of toxic byproducts, such as acetaldehyde, which I mentioned earlier. What acetaldehyde can do is it can cause lipid peroxidation, as well as the formation of acetaldehyde and protein adducts. These can disrupt the cytoskeleton and impede mitochondrial function. In addition, alcohol can directly affect mitochondrial function and membrane fluidity, causing injury to hepatocytes. And then we're going to get abundant reactive oxygen species in our central lobular area. This is going to be caused through alcohol oxidation, as well as a product of these neutrophils that are coming into the liver. Recall that one of the roles of neutrophils is to generate reactive oxygen species. With these abundant reactive oxygen species, we can get membrane and protein damage. And as I mentioned before, the generation of acetaldehyde and free radicals is maximal in the central lobular region, which is why that area tends to be affected. So what do we see? The findings are similar in non-alcoholic fatty liver disease as well as alcohol-related fatty liver disease, although the findings are more pronounced in alcohol excess. Now, microscopically, we'll see hepatocyte ballooning, so enlarged hepatocytes that are swollen and necrotic, and this is going to be most prominent in the central lobular regions. In addition, we will have the Mallory-Hyaline I referred to. These are tangled intermediate filaments, primarily keratins, that we find in degenerating and dying hepatocytes. And finally, we can see neutrophil infiltration. These particularly will accumulate around degenerating hepatocytes, particularly those with Mallory-Hyaline. So let's take a look here. This is an image from your textbook, Robbins and Kumar Basic Pathology. Now first I'd like to show you this little clump of intermediate filaments here. This is Mallory-Hyaline. And then here you can see a hepatocyte which has some Mallory-Hyaline within it, and it's surrounded by these inflammatory cells. Now remember, these inflammatory cells can be generating those reactive oxygen species, causing additional damage. Here's another image that again shows Mallory-Hyaline, this dark pink clumpy material here within this ballooned hepatocyte. There's a little bit more here as well. Now this can be very difficult to find. I don't think it's something that most instructors would expect medical students to be able to recognize. It's something that we too sometimes have trouble recognizing, so we can actually use an immunohistochemical stain for keratin. Remember, this is keratin is an intermediate filament, and we can see here that our hepatocytes are going to stain with keratin, as are these clumped intermediate filaments. And this is just again showing these ballooned hepatocytes with some inflammation. This brings us to our final step in our journey, which is steatofibrosis. So what causes steatofibrosis? Cirrhosis will develop in a small proportion of individuals who chronically consume excess alcohol. So what causes this? When you have the death of large numbers of hepatocytes, we can get the collapse of the underlying reticulin, so that framework on which hepatocytes can regenerate. We also can get activation of our perisinusoidal hepatic stellate cells that will then be transformed into fibrogenic myofibroblasts, releasing fibrogenic mediators, causing the formation of fibrous septa. These fibrous septa will encircle nodules of regenerating hepatocytes, and this is what we call cirrhosis. So what do we see morphologically? Grossly, the liver will have a nodular surface, and it may have a greenish tinge due to the buildup of bile. Now microscopically, initially again, the injury will be centrolobular, and we can see sclerosis around that central vein. With that perisinusoidal scarring, we get that chicken wire fence pattern, which I'll show you in a moment. And then we can also get these bridging septa of fibrosis from portal triad to portal triad. These bands of collagen will surround these nodules, but can also, we can see subdivision of these nodules leading to this micronodular cirrhosis. Now with abstinence, these nodules can regenerate, resulting in macronodules, and I'll show you a nice example of that in a moment. Here is an image of a cirrhotic liver from your textbook, and you can see here it has this very nodular surface. It also is somewhat shrunken and collapsed from fibrosis. This image shows the greenish tinge as well as these surface nodules, and this cut section shows you that this nodular architecture is diffuse throughout the entire liver. Histologically, we can appreciate the dense bands of fibrosis in this advanced cirrhosis here. This is using a trichrome stain, which stains collagen blue. So you can see how much collagen deposition there is here. This is what's going to contribute to our portal hypertension. And as we look on higher magnification, you can see this chicken wire pattern here, where you can see these individual hepatocytes surrounded by fibrosis. Now, it's important to remember, and also for counseling your patients, that with abstinence we can get some improvement and regression of this fibrosis. In fact, abstinence is the most important part of the therapy for individuals with alcohol-related liver disease. So here is a histologic image of an individual who is actively drinking and has cirrhosis, these dense bands of collagen, nodules of hepatocytes, and after only 1 year of abstinence, you can see that much of the fibrosis has resolved and the liver has adopted a more normal appearance. So I'd like to now go through the clinical features of these different findings and these different stages of alcohol-related liver disease. So with steatosis, the patient may be completely asymptomatic or they may be discovered on screening laboratory tests that are found to have a mild elevation of serum bilirubin and alkaline phosphatase. They may also have hepatomegaly that you may identify on physical exam. And this condition will resolve quite easily with abstinence. Steatohepatitis, however, is a little bit more aggressive. And it can occur after weeks to months of heavy alcohol consumption or after a heavy bout of drinking, and it typically will have an acute onset. The presentation can be simply malaise or anorexia, tender hepatomegaly, or fever. And then when you look at the laboratory values, you'll see hyperbilirubinemia, as well as increases in serum alkaline phosphatase, as well as your aminotransferases. I cover the laboratory tests involved in assessment of the liver in a video on acute and chronic liver failure, so please review that if you'd like some more information on these tests. Just to remind you, the aminotransferases we look at are aspartate aminotransferase and alanine aminotransferase. And when you assess these values, you will find that in alcohol-related fatty liver disease, typically the AST to ALT ratio will be greater than 2 to 1. This is different from what we can see in other types of liver failure. The levels of AST and ALT are typically, while elevated, are less than 500 units per ml. So this is in contrast to what we can see, for example, with autoimmune hepatitis, where you can get massive hepatic necrosis resulting in the release of abundant cytosolic enzymes. Now, steatohepatitis doesn't sound like it's that bad. We've got some elevations of some enzymes, a little bit of inflammation, but it's critical that you remember that each incidence of alcohol-related hepatitis has a 10 to 20% risk of death. And with repeated bouts of this, 1/3 of patients will develop cirrhosis over a period of about a few years. Now, this brings us to chronic liver failure and cirrhosis. Again, this is covered in great detail in the video on acute and chronic liver failure, but I'm including this here simply so you have this for reference to compare with our steatosis and steatohepatitis. These are the variety of findings that you can see in cirrhosis. And then this is a figure also covered in that video and from Robbins Kumar Basic Pathology, showing you the various findings of chronic liver failure. And again, the only real approach and the central, most important aspect for these patients is abstinence from alcohol. Now that brings us to our next entity, which is non-alcohol-related fatty liver disease, which has very similar histologic findings to alcohol-related fatty liver disease, but has a different etiology. It's associated with type 2 diabetes, central obesity, and dyslipidemia. Dyslipidemia is characterized by hypertriglyceridemia, low high-density lipoprotein cholesterol, and high low-density lipoprotein cholesterol. These patients are often hypertensive. As I mentioned, the histologic findings are similar. Inflammation is typically less prominent. We'll use the term steatosis. For steatohepatitis, this is typically referred to as non-alcoholic steatohepatitis or NASH. So that's something you might see in clinic notes. Steatofibrosis, of course, is what leads us to our cirrhosis. Now, the pathogenesis is very different in non-alcohol fatty liver disease. We have insulin resistance, and with that insulin resistance, we're going to get increased activity of our lipoprotein lipase, which will increase the release of free fatty acids. With abundant free fatty acids, we're going to get a decreased production of adiponectin by adipocytes. With this, we're going to get decreased oxidation of our free fatty acids by skeletal muscle and increased free fatty acid uptake by hepatocytes. So they're going to become bulging with lipid. In addition, we're going to get injury to our hepatocytes, which is going to cause activation of our inflammasome and the release of the pro-inflammatory cytokine IL-1. Furthermore, the products of lipid metabolism can be directly toxic to hepatocytes and can thereby activate stellate cells, leading to fibrosis. Let's put this together with a figure from Robbins and Kumar Basic Pathology. So here you can see our liver. We have our environmental factors that can include elements from the gut microbiome as well as dietary fat, leading to increased free fatty acids. This increased free fatty acids in and of itself can lead to triglyceride accumulation in our hepatocytes and our steatosis. We can also have metabolic factors such as obesity and an insulin resistance that again are going to lead to an increase in free fatty acids and a decrease in adipokines. These free fatty acids again will enter our cycle here, and this brings us also to our lipotoxicity from these free fatty acids that can lead to endoplasmic reticulum stress as well as mitochondrial dysfunction, leading to hepatocyte injury. With this injury, we're going to get inflammatory mediators, activation of our inflammasome. With this, we're going to get Kupffer cell and stellate cell activation. Our inflammatory mediators as well are going to contribute to our inflammation and fibrosis. So the clinical features of non-alcoholic fatty liver disease are that this is the most common cause of incidental transaminase elevation. Now, typically the AST to ALT ratio will be less than 1, which can help make the diagnosis. But I'd like to point out that you can only make this diagnosis through liver biopsy. Now, as we saw before with alcohol-related fatty liver disease, steatosis is typically going to be asymptomatic, often picked up on a screening laboratory test. When we have active steatohepatitis and fibrosis, patients may be asymptomatic or they may have fatigue, malaise, right upper quadrant discomfort. Fortunately, in this condition, the progression from steatosis to non-alcoholic steatohepatitis or NASH to cirrhosis is low, and the treatment for these patients will be weight reduction and a reversal of insulin resistance. So let's put that together in a figure to help you visualize the natural history of non-alcoholic fatty liver disease. So in more than 80% of patients, they will have isolated fatty liver with none to very minimal progression to cirrhosis and no increased risk of death compared to the general population. However, there's a subset that will progress to non-alcoholic steatohepatitis or NASH, and of these, about 20% will convert to cirrhosis over a 15-year period. Those with cirrhosis, 3 to 4% will undergo liver failure every year, and less than 1% will develop hepatocellular carcinoma. Non-alcoholic steatohepatitis can also go directly to hepatocellular carcinoma, which is covered as well in the acute and chronic liver failure video. As always, here are some questions to help you review the material I've just covered. Thank you very much for your time and attention. Please do subscribe. I sure would appreciate it. Thank you very much.